Welcome everyone to Health for the World International Grand Rounds. We are really honored to have our Grand Round speaker today. Our Grand Round speaker is Dr. Chris Potter. Dr. Potter is an emergency and neuroradiology faculty at Brigham's and Women's Hospital at Harvard Medical School. Dr. Potter did his medical school at UCSF, his residency at University of Washington, and also a fellowship in neuroradiology at University of Washington. Dr. Potter is an acclaimed neuroradiologist and a renowned speaker. We are really honored to have him to present our grand rounds on the topic neurological emergencies in the ED, head and neck. Thank you, Chris, and you can start whenever you're ready.
Okay, thank you very much. Thank you very much for the invitation, and I'm really pleased to be here to talk with you today. So let's see. Oops. So I don't have any relevant disclosures. I just wanted to show you a little a picture, first of all, of where I work. So this is Brigham and Women's Hospital. It's in Boston, Massachusetts. It's a 793-bed teaching hospital. This is where I work down here. It's an active emergency department, has both stroke and trauma. It's partners with Massachusetts General Hospital as well, which is also in Boston. And they form the Mass General Brigham Network, and we're the largest network in Massachusetts. So we see a lot of patients, and it's an interesting place to work. So today we're going to talk about some important imaging of head and neck emergencies and the appearance on imaging, and we'll talk as we go about some relative anatomy or relevant anatomies, so that we won't focus too much on anatomy, but there are a small amount of anatomy that it's best to be able to navigate the head and neck imaging. All right, first of all, let's talk a little bit about the sinuses. Excuse me. So what do we do for the sinuses in the emergency department? Mostly we image for complications. We tend to see sinus CT more in neuroradiology for things like chronic problems. But in the emergency room, we want to know, is there infection, and is there intracranial extension of infection? Is there soft tissue extension, or is there orbital infection? So what do we use to figure that out? MRI is really the best option to look for intracranial complications. CT can also be very helpful as an initial imaging strategy, or if you don't have MRI available. So let's look at a case. So this is a patient that came in with a headache. Patient had type 2 diabetes and a finding of new diplopia, a 76-year-old man. And the headache had been worsening over 5 days. So what do we see here that's important? First of all, in the clinical history, the two things that are important are new diplopia. That makes us pretty worried. The patient also has diabetes type 2, which means that they are relatively immunocompromised. If you look at the image, you can see the maxillary sinuses here are pretty opacified. That's not very specific for a problem, an acute problem. The walls of the maxillary sinus are also somewhat thickened. That's somewhat suggestive of a chronic problem like chronic sinusitis. But the thing that's subtle, that's worrisome on CT, that's something to take away from this image, is where the yellow arrow is pointing. That's the periantral fat pad around the maxillary sinus. And you can see that there's a little bit of fat stranding here, though there's a little soft tissue density in this fat plane. And that is a very concerning finding for an invasive sinusitis. And if you, the nice thing in the head and neck is that we usually have another side to compare to. So if you look at this fat plane, this is a normal one. So this is nice and clear. This is the way it should look. And there's some subtle fat stranding here. One other thing to take away is that there's, see this little bit of soft tissue right here. This is a pterygoid plexus here. This is a normal finding. You know, you have another one on the other side, so you can use symmetry to kind of figure out whether it's normal. But that can be a kind of fooler, so don't get fooled by the pterygoid plexus, but do recognize that this is abnormal if you're worried about a sinusitis. And this is the same patient. So this is a non-contrast head CT a little further up. So this is the frontal sinus on the left. You can see it's completely opacified. You also see that the bone is intact, and that's an important finding, and I'll tell you in 1 second when we see the diffusion weighted image. And the diffusion weighted image is clearly abnormal. So what's going on here? There's diffusion hyperintensity in the left frontal sinus, and that's what you would see if there's an infection, such as intracranial abscess has the same diffusion hyperintensity and low ADC value, so low diffusivity. Also, there's intracranial spread of infection. There's similar hyperintensity here and a pretty large left subdural collection as well. And you can see the point I'm making here with CT is that the bone is intact. So MRI is really the best way to look for intracranial spread of infection, because you can have intracranial spread of infection with an intact bone. You don't need to see, sometimes you see bony erosion, and that indicates that there's a problem. So CT can be helpful, but often you'll see the early signs of sinus complications on MRI, and you won't necessarily see them on CT. So let's look, this is this patient's MRI. So we can see a flare image on the left and a post-contrast image on the right. And you can see that this, there's a flare hyperintensity in the parenchyma here due to some encephalitis and the nearby collection. There's a subdural empyema here. And there's some midline shift with a little bit of fluid density, so increased flare hyperintensity around the atrium of the right lateral ventricle. And that's due to the midline shift, some obstruction, and then some subependymal flow of CSF due to the obstruction. So what do we see on the post-contrast? We can see this collection, and this is typical of an empyema. As we saw on the previous slide, you can see this diffusion hyperintensity in the collection, which is typical of an infection. However, you can also see increased diffusion signal with hemorrhage. Something you don't tend to see much with hemorrhage. You see less often, you see dural enhancement, this kind of thick enhancement here, although you can see that with a chronic hemorrhage. The thing you don't tend to see with an chronic hemorrhage or an acute hemorrhage is leptomeningeal enhancement, and that's this enhancement here. It follows the sulci because the leptomeninges follows the sulci, so you can see this sulcal enhancement here. That's unusual for a hemorrhage, and that's typical of a subdural empyema. All right, this is another patient. Sorry for this. I don't know if you can see that this these lines through here. I think that's a transmission problem, but the let me just try doing this again. And okay, that seemed to help. Okay, so this is another patient. These are complications of acute sinusitis continued. So we see the post-contrast image on the left and the diffusion weighted image on the right. Again, similar findings, intracranial findings. You see this parafalcine subdural collection here that's hyper intense on diffusion weighted image. That's typical of an empyema, although it could be a hemorrhage. The thing that we tend to see with empyemas, though, is this leptomeningeal enhancement here, and then the dural enhancement to kind of solidifies that impression. You can see that this infection has decompressed into intracranially and also extracranially. I'm not showing you the sinus infection, but we can see the complications of it in that it must have eroded through the intertable, or have extended through the intertable into the intracranial space. And also here, this is what's been called Pott's puffy tumor. So before we had imaging, you'd be able to feel this in a patient with sinusitis and know that the infection had spread from the sinus or decompressed from the sinus into the soft tissues. And you can see the same imaging findings of diffusion hyperintensity and this peripherally enhancing fluid collection. So here's another patient. This patient also has findings, clinical findings, suggesting acute sinusitis. Patient has CLL, chronic lymphocytic leukemia, and so that means that the patient is immunocompromised and they have facial pain. Excuse me. So what do we see on the image to the left? We see this completely opacified sinus. We can see this inspissated material, which is usually kind of dried up gunk in the sinus that's a little bit denser because it's proteinaceous. And we also see the same sign, worrisome sign that we saw on the last patient with the CT. You can see here's the normal periantial fat pad. This one has fat stranding in it. It's subtle, but we can see it. As we look more closely, you can also see that there's fluid around the pterygoid plates and extending into the nasopharynx. So right away, we know that this is invasive disease, as we can see on this CT. Here's a little bit more superiorly. We can see, take a look at the cavernous sinus there, and then compare it to the one on the right. And you can see there's no opacification in the cavernous sinus. It's a little bit expanded. And also within the cavernous sinus, you can see actually the left intracranial internal carotid artery is not opacified either. So that's a very concerning finding. And we also see this collection here, right next to the opacification of the ethmoid sinuses. So this is an orbital abscess, and there's cranial spread of infection via the cavernous sinus, and now we have thrombosis also of the internal carotid artery. Unusual complications of sinusitis, but part of what can happen. So always orbital abscess is a fairly common complication of acute sinusitis. Less common complications are cavernous sinus thrombosis after extension from that orbital abscess posteriorly. And also carotid occlusion is rare, but can happen. And it's important that you keep those vascular complications in mind, because those might not be the first things that you have in mind when you're thinking about complications of sinusitis. Okay, taking a step back for a second, let's just talk a little bit about acute invasive fungal sinusitis. So most of the time when we're worried about invasive sinusitis, you can have invasive bacterial sinusitis, but more often it's due to a fungal etiology. And we split clinically in fungal sinusitis into two main groups because of their clinical presentation and their outcomes. And that's a group, the people we worry about, which are people who have acute invasive fungal sinusitis, and then the less worrisome findings due to chronic fungal sinusitis. So what we've been talking about is acute invasive fungal sinusitis. It has a fulminant spread. It spreads very quickly. Tends to happen in people who are immunocompromised for various reasons. And it has a relatively high morbidity and mortality. So we have to treat it very quickly to be able to help the patient. In terms of chronic fungal sinusitis, it tends to happen in people who are immunocompetent. That's a chronic finding. It's usually not life-threatening. You can see sinus calcification, which tends to, anytime you have calcification, it usually indicates that it's a more chronic process than an acute process. And you tend to get thickening of the bony paranasal sinus walls, like we saw in that first patient, that suggests that there's a chronic component. And you can see here, this is a patient with acute invasive fungal sinusitis, like we've been talking about before, and you can see how much this is spread. This looks like it may have started in the orbit and it's really spread intracranially with the dural enhancement here. It's spread into the cavernous sinus. So this is going to be a really big problem. This is the same patient actually and had had diabetes type 2 and presented with new left blindness, obviously a very ominous finding. And you can see the debris in the CT here on the axial images. And you can see this hypodensity on CT. So we know something has extended intracranially. And they got an MR afterwards, and we see this diffusion weighted imaging showing the diffusion restriction due to the abscess. And as we saw on that previous slide, all of this involvement of the orbit and very extensive involvement. So it's important to try to recognize these cases quickly and image them quickly. The best thing that we can do for the patient is have the clinician be aware that of the clinical findings of acute sinusitis and let us know that. The best imaging test is MRI, but CT can be helpful if that's what you have to use. And here's that same patient. I just wanted to show you that there's a little bit of erosion of the roof of the sphenoid sinus, but not a lot of bony erosion in this case, but a lot of intracranial extension. Already it's spread quite far by the time we see it on CT. All right, let's talk next about the orbits. We'll switch to the next location. So, question on these two images. So these are different patients. How do we describe the locations of these abnormalities? And the reason to ask that is that treatment of the orbit is in the emergency department is really based on where you locate the lesion. So of the where you locate the abnormality. So here we can see this soft tissue thickening. It's pretty superficial. And then here we can see the, sorry, I don't see if my arrow comes up. Okay. Here we can see a little collection more posteriorly. So let's talk a little bit about anatomy right now. So one of the important things to remember in the ED context is, in the emergency context, is there is the orbital septum, and the orbital septum is a very important structure because it is a very effective barrier of infection. So it really prevents things quite efficiently from getting from the outside to the inside of the orbit. And where is the septum? Well, we can't really see it. Well, you can't see it by eye. You can't see it on CT. You can sometimes see it on MRI if it's a high resolution MRI, but we do know that if you look at a CT image on the axials, you can see that it lives about here. So in the medial canthal region. So if you drew a line to somewhere anteriorly near the extraocular muscle insertion, and from the anterior lateral orbit over to the same location, that's the approximate location of the orbital septum. So it's, and we can use that as a ballpark for the orbital septum. And so how we usually describe this, we can describe these spaces in two ways. So more superficially, we describe this as the preseptal space, and the deep orbit here is the postseptal space because this is the orbital septum. There's two older terms too that are still in use, and that is periorbital, and periorbital just means preseptal. And then orbital means postseptal. So if you have an orbital hematoma, that means it's behind the septum. If you have periorbital swelling or periorbital cellulitis, it means it's preseptal, so it's before the septum. I like preseptal and postseptal because it implies the location and some of the meaning a little bit better, but you'll see both in use, so it's good to be comfortable with both things. There's intraconal, extraconal is also a terminology that we use, not so helpful in the ED imaging. more helpful in neuroradiology. Okay, so let's look at our first patient again, and you can see that there's this swelling, oops, superficially right here. Here's the orbital septum, and you can see it really doesn't involve the orbital space, the postseptal space. So I would call this a preseptal cellulitis or a periorbital cellulitis. And here's our second patient that we saw that was on the other side of the screen. And you can see here, right adjacent to the ethmoids and the lamina propria, which is this very thin bone right here, we can see this collection that's extends really behind the septal space all the way to the posterior, the apex of the orbit. So this is a orbital abscess or a postseptal abscess. So this is something that we would be much more concerned about. And why are we concerned about that? Well, if you have a periorbital cellulitis or a preseptal cellulitis, the danger of it spreading into the cavernous sinus or into the brain itself is fairly low. But once you have crossed that orbital septum, there's really no barrier for infection to stop infection from moving into the cavernous sinus and into the intracranial space, which is then very dangerous. So so we need to be a lot more aggressive about treating infections or other lesions like that in the postseptal space. Okay, so let's talk a little bit about an orbital infection or postseptal abscess. So it's often a complication of acute sinusitis. Like I showed you before, there was, in the last case, there was this opacification of the ethmoid sinuses, and it easily moves through the lamina propria into the orbit. Here is a different location, but still a small orbital abscess. What's part of the problem with the orbital infection? Well, it causes pressure. That pressure causes proptosis, and it moves the globe outside of the orbit. That can cause pressure on the central artery, or it can cause venous occlusion, which can cut off blood flow to the globe. And it can also move can also stretch the optic nerve that can cause further ischemia and injury to the optic nerve. So it's important to look at the globe in the setting of an orbital space occupying lesion and look at the posterior aspect of the globe. Because as you can see, there's a little bit of globe deformity, right? This should be nice and round. This is slightly V-shaped. So this is something you'd want to see. You want to tell the clinician seeing the patient there is some orbital tenting, which means that there's some increased pressure on the globe, and that they should have somebody, may need to decompress this area, like an ophthalmologist. So this is when it gets really bad. So this is, you can see how much tenting there is of the globe. You can see that this is a V shape here. So there's a lot of pressure on that optic nerve. There's a lot of, there could be vascular compromise, and this patient is at risk for losing their sight. So this is an ophthalmologic emergency and needs to get treated right away. So when you're looking at the orbit and looking at orbital infections and space occupying lesions, make sure to look at the globe and look posteriorly at the globe to see are we going to be in trouble due to the proptosis that's happening in the orbit. Okay, this is another patient who has pain and proptosis, and you can see this is a CTA, and this is a different etiology for pain and proptosis of the orbit. You can see on this CTA, there is a little bit of, you can see the relative proptosis. Here's one side, here's the other. It doesn't look like it's from malalignment. And you can see that there's enlargement of the superior ophthalmic vein on the left. And there's also some early opacification. We're still in a pretty arterial phase here. There's not much opacification here. There's relatively increased opacification. And this is a cavernous carotid fistula. So what is that? That's an abnormal arteriovenous connection through the cavernous sinus. There are two different types. One is called direct, the other is called indirect. The direct you tend to get through trauma or sometimes through the bursting of an aneurysm, which means there's a hole in the carotid artery as it passes through the cavernous sinus. And there's blood flowing directly from the artery into the vein there. And those usually appear right away. They're severe, and they're often due to trauma, maybe a few days after the trauma, because the person has had a pseudoaneurysm that's then ruptured. Indirect cavernous carotid fistulas are more sneaky. They happen over a longer period of time. They're usually due to a smaller artery branch that then that's connected to the cavernous sinus and causing an arteriovenous connection. And that can be due to, there's a variety of causes. They're usually due to some sort of vascular, abnormality like hypertension, atherosclerosis, collagen vascular disease. Also childbirth has been known to happen as well. These tend to get diagnosed later, the indirect kind. So what do you usually see? Chemosis, which is redness of the eye, that actually is scleral redness. Patient has pain. As it progresses, they lose function of the eye, so they can get ophthalmoplegia. That low flow kind, the kind that's not caused by trauma or an aneurysm bursting right away, those are often misdiagnosed for a couple months, often as conjunctivitis or cellulitis, and it's just not getting better. And so that's something to think about, is could this person have a cavernous carotid fistula? Because endovascular treatment has been very successful with these. This is the same patient, you can see, just to show what it looks like on MRI, and you can see this flow void and the enlargement of the superior ophthalmic vein. And I actually happen to be involved in this case as a trainee, and we did a cerebral angiogram. So here we're injecting the right internal carotid artery in the neck, and you can see the opacification. It's on a bit of a later phase, but you can see that here's the arterial tree right here as we go into the internal carotid artery, the middle cerebral artery, and the anterior cerebral artery here. And there's this abnormal communication here. We shouldn't really see anything on the left side, and what we're seeing is a venous structure here. So this is the superior ophthalmic vein as it enters the orbit, and so that's quite abnormal. So there's an abnormal arterial connection there. We canalized the left jugular vein and catheterized the superior ophthalmic vein through the petrosal sinus there. And you can see after the embolization, here you can see the embolization coils. There it was before. And now you can see that there's really nice opacification of the arteries and no residual opacification over here. So, and the patient the next day was feeling good. Here's another case. This is also a cavernous carotid fistula, just to show you a little bit more how it looks on MRA. And you can see here's the arterialized, there's the intracranial arteries. So they have flow-related enhancements on MRA, so they're bright, right? And the veins shouldn't be bright, but this vein is bright. This is the right superior ophthalmic vein. So this has arterialized flow in it. And this is the same patient, and you can see on the left side is normal, and you can see this flow-related enhancement in the left internal carotid artery, but we can see actually decreased flow-related enhancement in the right internal carotid artery relatively, and flow in the cavernous sinus, which shouldn't be there. So this is also, this is a patient with Ehlers-Danlos syndrome, which is a connective tissue disorder. So this is one of the complications of the disease. Here's the same patient during treatment, and you can see in the connective tissue disorder, we can often see these abnormalities like this vascular ectasia. This is actually the carotid artery. You can see how irregular and deformed it is due to connective tissue abnormality, and you can see this abnormal venous collection here. And this patient was embolized as well. You can see all the embolic material there, and they did quite well afterwards, and all that connection to the left side is better. Okay, here's a different patient and a different entity. This is on the differential for eye pain. So this is a patient with acute pain with eye movement. And you can see there's enlargement of the left medial rectus muscle. And there's this fat stranding behind that. So what could that be? Is it something inflammatory? Is it something infectious? Could it be metastatic disease? Those are all on the differential diagnosis for this abnormality. And here we see it on the coronal, and you can see how thickened it is compared to the other side right there. And you can see there's subtle fat stranding. And it's really just this medial rectus muscle there. This turned out to be orbital pseudotumor. So this is another entity that can cause eye pain. It's an idiopathic orbital inflammation. So it's usually a diagnosis of exclusion after you've figured out that it's not all these other things. It usually has a fairly acute presentation. You get pain, inflammation, proptosis, and it's can look like a lot of things. Often it involves the extraocular muscles like this one, but it can involve just the fat. It can be very diffuse. It can be very focal. It's more often unilateral, but it can be bilateral as well. And what do we see? Well, like I said, it could be kind of focal or infiltrative, and you tend to see this, the kind of typical pattern is really this enlargement of extraocular muscles, kind of shaggy border due to this fat stranding and some increased enhancement due to the inflammation. Here it is just on MRI, and this is from a radiographics article a couple of years ago. It has a variable appearance on MRI because sometimes you can get a really bright look from the increased edema and water in the orbit, or you can get actually low T2 signal, which is due to the inflammation and kind of scarring, I think probably is what's causing it. And similar to CT, it can be focal or infiltrative, and you can have a lot of enhancement, as in this image right here, this fat saturated post-contrast image. There's just a lot of enhancement in the orbit. Right, so here's another, this is on the, another differential for eye pain. Often can be kind of hard to tell from orbital pseudotumor, and this is thyroid eye disease. So as you can see, there's a lot of similarly, it has enlargement of the extraocular muscles. You can see how enlarged these extraocular muscles are right here. And it can cause pain, proptosis, also visual disturbances, but it tends to have a longer onset. It usually kind of is insidious, so the patient may not know when exactly it started. It's more often bilateral than unilateral, although it can be unilateral. We think in the diagnosis of thyroid eye disease, we use this mnemonic, I'm slow is an effective one, and it reminds you the order of extraocular muscle involvement. I often, the cases that I've seen usually spare the lateral rectus, so that's an easy thing to remember, is if you see that the lateral rectus is relatively spared, and you can see that this one is very thick, the medial rectus muscle is thickened, on both sides the lateral rectus muscle looks pretty normal. If we go back to this slide here, you can see these are relatively unaffected, whereas these extraocular muscles are affected. So that's an easy one to remember, is the lateral rectus tends to be fairly late in involvement in thyroid eye disease. Also described has been it spares the extraocular muscle insertion. I can never really tell. So maybe some people can get that right, but that for me is very hard. I don't find that as useful as the extraocular muscle sparing. All right, let's move on to mouth pain. So here's a patient with mouth pain, and let's talk a little bit about anatomy of the floor of mouth before we talk about the particular entities. So Here is the sublingual space on axial. You can see here's the part of the intrinsic muscles of the tongue. So this is the genioglossus muscle right here, medially. Then you have this sublingual space, which is fat and vessels and a few other things. And then you have this important muscle to remember, that's the mylohyoid. The mylohyoid forms a sling in the floor of the mouth and is an important landmark for head and neck imaging, and one of the things you should remember for emergency head and neck imaging. Another important muscle that I find is really helpful is the platysma. It's this little thin muscle that lives between the fat layers, and it's one of the muscles of facial expression, but can be kind of a really nice indicator of abnormalities on head and neck imaging, and so I use it all the time. So let's go back to let's look at the coronal plane, and we can see here's the sublingual space right there. Here's the genioglossus again. So the intrinsic muscles of the tongue are right here. This is just below the tongue. And here's our mylohyoid, and that does look more like a sling on coronal right here. It's kind of a U shape. And the mylohyoid divides the sublingual space and the submandibular space, which is right here in yellow. And the submandibular space is where the submandibular gland lives, although it does poke up superiorly into the sublingual space as well. And here's the platysma right here. So it's superficial to the submandibular space. And you can see that there's an abnormality here, right? And what is going on here? Well, this is cellulitis. We don't see an abscess looking through here, but there is inflammation. And I'll point out some of the things that I use in the head and neck, because things in the head and neck can be subtle. Sometimes you don't know much about the patient, then they might just say pain. So some of the indicators that you can use to figure out, well, where is the pain, and help you locate an abnormality that can sometimes be subtle. One of those things is cutaneous thickening. I often look at the skin. You can see here that the skin is actually much more thick on this side than this side. This is kind of more normal for this patient, and this is thickened. So that's fat stranding. Often we see first. Here's a subcutaneous fat stranding here, and there's a little bit of fat stranding in the submandibular space right here. The platysma is really helpful in that oftentimes when you have inflammation of the head and neck, you do get platysmal thickening. So there's some thickening of the platysma here that kind of points you to the side where the abnormality is, if you don't already know it. You can also see the mylohyoid here. This one looks thickened compared to this one. So there's some myositis of the platysma and the mylohyoid, and there's even a little bit of fat stranding in the sublingual space. So this is cellulitis without an abscess. All right, so this is actually the same patient, and this patient had continued mouth pain, and now they have a collection here. So this we know is a collection. Whether it's drainable or not, it's a little hard to tell, but there is some peripheral enhancement here, which suggests that it may be a drainable collection. And then it's right next to the bone, so we're suspicious that this is an odontogenic abscess. So we see these fairly often. So how do we help in the setting of odontogenic abscess with cross-sectional imaging? Well, we can help be confident about where the abscess is and to say how large it is in terms of where to drain. So one thing to look for on a CT in terms of odontogenic abscess to define the site of the abnormality is to look for cortical dehiscence. So what does that mean? And you can see here, I wanted to point out the peripheral enhancement, and these abscesses tend to be subperiosteal because they're decompressing from an infection in the bone. So you can see this enhancement around it, and it's right next to the bone there. So that's typical of an odontogenic abscess. And here's cortical dehiscence. So here's a periapical lucency. This is due to inflammation in the tooth, and this can be sterile or it can be actively infectious depending on the context. But we see this, this patient has inflammation, and you can see that there's a little loss of the outer alveolar cortex next to this periapical lucency here, so we suspect that this is the site of active infection that's decompressing into it. And that's the area that we saw the subperiosteal abscess. Also helpful to comment on dental disease, other dental disease that could affect the patient, like does the patient have a lot of dental caries in other locations or other periapical lucencies that the dentist should know about. So when we take care of that tooth, are there other teeth that need to be taken care of as well to help this person? Okay, here's moving on to a different entity. This is a patient with floor of mouth pain, and this is a CTA. So I'm gonna just kind of help you out a little bit, and we'll point out the everything's hyperdense there. So here's some calcification. This is in the submandibular gland right here. And this is acute sialadenitis. So what do we see in acute sialadenitis? We see this enlarged, enhancing gland here. Sometimes, we often see a stone as we did before. Sometimes we can see ductal dilation as we see here. You can see the branching duct that's obstructed into the submandibular gland. We can often see some cellulitis and myositis next door. There's a little bit of fat straining next to this submandibular gland. Complications are fairly rare, but you can see abscess and occasionally some airway compromise. Here's an unusual case. This is sialadenitis, and this patient has an abscess, and you can see this hyper-enhancing, enlarged submandibular gland here, and you can see this abscess is actually decompressed into the submandibular space, and kind of here's I think the mylohide is probably stretched here, and it's pushing everything to the left. And this patient does have some mild airway narrowing, and it's always important to look at the airway in head and neck cases because you can help the clinician out by pointing out a narrow airway that they may, if things get worse, then they may need to act on that and put in a supportive device. All right, let's talk about foreign bodies. This is a fishbone. We see this not infrequently. Sometimes you can see the foreign body on particularly bones. Sometimes you can see it on radiograph. Usually you can see it on CT. They can both be helpful depending on what you have available. Foreign bodies tend to be oriented in the direction of the esophagus. So when I look for something, I'm looking for something relatively in the direction of the esophagus. There are a lot of mimics of foreign bodies in the neck, and there are some good papers published on that that you could maybe access to look for some. But one thing to remember is when you see a foreign body, it's usually going to be oriented in the direction of the esophagus. Sometimes it can be oblique. If it's oblique, you want to look carefully to make sure it's not a mimic. And if it's not a mimic, that oblique orientation can suggest that there may be increased risk of perforation because they tend to be oblique when they perforated the wall and then the wall is kind of spasming and moving them. So it's important to really window effectively. So what do we want to do? So there's actually a foreign body on this radiograph. So what do we want to do? We want to window very narrowly and then mag up. So, and you can see there's the fishbone. So there we can see it, but really impossible to see on this image without changing your windowing and leveling. So it's important to window and level to be able to look for these things and look for something in that region of the esophagus. So that's what it's going to look like. CT is a lot easier. Here's the same patient. This was a CT, and you can see this abnormality here. So that little linear hyperdensity in the esophagus is the fishbone, and it's kind of stuck in there. And here's the borders of it. So here's the wall of the esophagus, and we can, important on this to note what the information that we wanted is this perforated or not? And there's nothing extending through the wall, and there's no gas outside the wall to suggest that there's perforation. Foreign bodies in trauma are always good to look for, and they can easily be missed. So this is a cervical spine. Usually we're concentrating on the body and not on the things going on around it. It's right next to this endotracheal tube and nasogastric tube. So it's easy to miss that on a trauma scan. Scout views can be very helpful. So here's the scout view of the same patient, and we see this is what we were seeing in the neck right next to this endotracheal tube and the nasogastric tube. And what is that? That's a dental crown. So it's they can often be knocked out of place either by the primary trauma or by intubation and the supportive measures that are being taken in the field. And if the patient is intubated, it's sticking in the throat and it may need to be removed before extubation, because what can happen is if it's not removed before extubation, the tube gets removed, it gets aspirated into the lungs and can cause an abscess and cause problems down the road. And so it's a good idea to look for foreign objects and foreign when you're evaluating a trauma CT. Sometimes we see them, the patient swallowed them. Usually they don't present a problem when they're swallowed. At least the teeth don't. Foreign bodies in kids. So the thing that we worry about here most is our button batteries. So these can be a real problem. This is the second most common place for them to get lodged. We think of them being swallowed. They can also be put up the nose because kids put things in their noses, and they cause damage by a variety of ways, leakage of chemicals. And they cause an alkaline environment, which can burn the tissues, and mercury toxicity specifically can be a real problem from these. And one thing to be quite careful of is that, sometimes we think often kids swallow coins. Coins can look like button batteries. Button batteries, or button batteries can look like coins. If you see this image down here, these look a lot like coins. So if you're calling something a coin on a radiograph but don't have any more information, I would be very conservative about that and look into it, because you can get fooled and it may be a button battery that can cause a lot of damage. Okay, let's look at a couple patients who have sore throat and swelling. So this is patient 1 on the left and patient 2 on the right. And let's think about that a little bit. First, let's talk a little bit of anatomy. So this is the parapharyngeal fat plane here in red. It's a very useful compass in the head and neck. So it can tell you various head and neck abnormalities can move it one direction or another. And I'll show you where it's useful in a little bit, but it's mostly fat, and it's a helpful indicator in areas of infection or masses or other things in the head and neck. So let's take a look first at this patient 1 who has sore throat and swelling. This is a patient with tonsillitis. So in this patient, we don't see any low density collections to suggest an abscess. Tonsillitis can sometimes, you can see a striated appearance in the tonsils. Sometimes they can both be enlarged, and we kind of has kissing tonsils where they're very enlarged. The differential for this includes lymphoid hyperplasia. So this is our patient number 2, and this is the more worrisome patient. So this is a tonsillar or a peritonsillar abscess. So we can see this low density collection in the palatine tonsil and a little bit of edema or phlegmon in the parapharyngeal fat plane right here. And that's common. And make sure to comment on the airway narrowing. So sometimes we talk about these as tonsillar abscess. Sometimes we talk about them as peritonsillar abscess. So what's the difference? The difference is in kids, the infection is usually restricted to the tonsil. In adults, the infection has always extended outside the tonsillar capsule. Just we can't see the tonsillar capsule at imaging. So some people call it a tonsillar abscess in an adult if it's what they can see is really in the tonsil. Some people always call it the peritonsillar abscess because there's always a little bit of peritonsillar extension in adults. Essentially, the important thing in this abnormality is to describe what it is, because where it is and its extension into the nearby spaces dictates the surgical treatment of this or the emergent treatment of this. So if the abscess is really just centered in the tonsil, transoral drainage may be very effective for this. They may just be able to go in with a syringe and aspirate pus, and then the patient may be done. If you have more extensive spread of infection, as you can see here, here's a tonsillar abscess with extension into the masticator space. There's a little bit of extension into the carotid space. This may necessitate a more aggressive surgical approach depending on the patient. So that's the importance. So the important thing is to describe where this has spread. So I wanted to show you where the peripharyngeal fat plane can be helpful. So this is this a peritonsillar abscess? This was actually initially diagnosed as a peritonsillar abscess, but is this a peritonsillar abscess? So let's look at it for a second. Here's this low density collection right there. And it's next to the bone. Let's see where the peripharyngeal fat plane is. The peripharyngeal fat plane is actually being moved posteriorly and medially. So if this were arising in the palatine tonsil, it should be really moved laterally. So this can't really be from a tonsillar infection. This actually, or we don't suspect that. So we have to suspect something else. So this looks like it's moving anteriorly from more of the masticator space. And this turned out to be an odontogenic abscess. So this is where the problem lies. There's a periapical lucency, cortical dehiscence here. This odontogenic abscess is actually decompressed into the soft tissues here and mimicked a peritonsillar abscess. So a couple complications of abscesses to be aware of. Sorry. You can see here, there's this low density here in the retropharyngeal space that's pretty prominent. So this is what we call the danger space. And the problem with the retropharyngeal space is that it extends from the skull base all the way down to the mediastinum. So it can cause a lot of problems. And you can see that this collection actually extends all the way to the carotid space. And if you were looking on the, if you saw this on the last case, you can see, or on the last slide, you see this is actually the internal carotid artery. This is a big carotid pseudoaneurysm. This is a rare complication of peritonsillar abscess, but it's important to think of vascular problems when you're looking at peritonsillar infection. So you can get internal jugular vein thrombosis, you can get carotid artery spasm, you can even get carotid pseudoaneurysm. So look for these things and think about the vascular complications when you're looking at tonsillar and peritonsillar abscesses. Okay, so the, let's see. So I have a few more slides. Why don't we look at, a couple more cases and then I'll stop there because I've gone a little bit slower than I thought I was going to go. But here's our next patient. This is a patient with throat pain and stridor. And you can see the enlargement of the epiglottis here. You can see the epiglottis is markedly enlarged and actually a little lucent. And this is epiglotitis. We used to see it more often in kids. It depends on where you live and what the epidemiology is, but more often now we see it in this kind of patient. It's an older, unvaccinated adult. So we can see that this is the epiglottis. Here's the vallecula. Here's the epiglottis, and see it's markedly enlarged, and you get this kind of thumbprint look to it. So there's enlargement of the aryepiglottic folds as well. And there's airway narrowing, which is the primary problem with these people. Turns out that airway narrowing with adults is not as much of a problem as with kids due to the, the caliber of the airway, but something we still have to worry about. Let's look at our last case. And I'll stop there after this so that we have some time for questions. So here's, I wanted to show you this one. This is a patient also with progressive dysphagia and a sore throat. And you can see here, when we take a look at this, this is a pretty busy slide or a pretty busy image, but we can see all of this fluid. Boy, the more you look, the more you see. This is anterior in the neck, this posterior in the neck. but so this is a big complex abscess. So, but what is one of the important things to take away from this is extended posteriorly into this retropharyngeal danger space. So are we done with this imaging? So we're not done until we know exactly the extent of this. And given the location in the retropharyngeal area, this danger space, we have to make sure that we see the mediastinum, because and this collection does extend all the way down to the mediastinum, both anteriorly and posteriorly. We can see there's abscess extending down here. So this is a case of, This is a case of mediastinitis, and you can see how extensive this collection is. So it's a disease with high mortality, and head and neck infections can extend to the mediastinum and via the retropharyngeal space or the danger space. And where does that? It's behind the pharynx, so, and it's extends from the skull base all the way down to about the T3 level. And it's a rapid path of infection from the neck into the chest. And we want to alert surgeons about this early, because early detection, treatment, and maybe debridement can actually help this patient and save their life. So it's important in any head and neck infection to see, does this extend to the retropharyngeal space? And if we see extension there, we want to know how far down does it go. So we're not done until we interrogate the space. And I think I'll leave it right now there, since we have, some time for questions. And I thank you very much for your attendance today.
Thank you very much, Dr. Potter. Can you see the questions now?
Let me see.
Okay.
Let me see that. There's a chat. I can see this in the webinar chat.
Okay.
Let's see.
Thanks very much, Chris.
Thank you very much for all of your comments. Thank you.
So let's see. Looking at the questions here. This was an excellent talk. First of all, we have lots of good talk comments here. So I'm going to read those a little bit later after the questions. The question, one question we have is, what CT and MRI protocol are you currently using for invasive fungal sinusitis in the head and neck?
The CT protocol, we use our standard CT. So we do axial thin slices through the head and neck. I think if we know about it ahead of time, I would use contrast. If we don't know about it ahead of time, we wouldn't use contrast. I think contrast can be helpful. Most often in the CT, you're looking for bony erosion and then that periantral fat stranding. So contrast will be helpful, but without it, you don't really need it. In the MRI, we use a MRI orbit protocol usually. So that would be, in the orbit protocol, we really focus on this area of the face, and we usually get some sort of post-contrast and T2 imaging of the orbits, as well as usually fat saturated sequence, because that fat saturation suppresses the fat of the orbit and can help you see both the T2 and the post-contrast abnormalities better.
Perfect. Okay. Then the next question is, how do you distinguish infection from malignant lesion in the retropharyngeal space?
In the retropharyngeal space, I think clinical presentation is going to play a big part of that. So, and the imaging appearance, I think it's really going to depend on the malignancy. I haven't seen too many. I can't really think of a malignancy that I've seen that's really forming a collection in the retropharyngeal space.
Right.
Like a discrete collection with surrounding fat stranding. Most of those things I think are going to be infectious. I can't promise you that that's true, but in my experience, that has been.
Right, right. So I think since we are running out of time, I'll just read out. So we have lots of good thank yous from around the world. We have greetings from Dr. Nakuru, from Nakuru, Kenya, from Dr. Pramalik, from Dr. Jacqueline Gabon. I'm just reading out Dr. Enrique Menro from Mexico, Dr. Juan Ovalle from Colombia. Thank you for the excellent lecture. It was great. Regards from Colombia. Dr. Aditi Charusia from India. Thank you, Dr. Potter. Very informative talk. And then from Hasna Nuhu, excellent presentation. Dr. Rose from Kenya, thank you very much. From Bhutan, excellent talk from Dr. Dechen. Great presentation from Dr. Andrea Apu from Kenya. Excellent conference with very exemplary clinical cases. Thank you very much. Dr. Ernesto Dana from Mexico. There are lots of good comments. I'm just going to read a few more. Dr. Potter has an incredible material. Thanks for the helpful presentation. Good day from Freetown, Sierra Leone, from Dr. Len Gordon Harris. Greetings from Monterrey, Mexico. Thanks for the excellent talk. Excellent talk from Bantagas Medical Center, Philippines. And I think, yeah, Dr. Enrique Menro from Mexico, excellent talk. And thank you very much for the nice lecture from Dr. Mocha Jacob from Tanzania, who has been leading a collaboration there. So I really appreciate you doing this for us. Clearly, this was very impressive and really well received. And there are more popping up, so I think we have to just wind up now. So
thank you very much. It's my pleasure to be here.
Yeah, and and this was a very pertinent topic for our audience, and I really appreciate you taking our time to do this. And thank you very much for radiology faculty and residents from around the world who joined in for this talk. And I hope everyone stays safe and well during these times. All right, have a good day, everyone. Take care.
Well, thank you.
And thanks. Bye-bye.
Thank you very much again, Dr. Potter. I'm going to end the webinar now.
My pleasure. Thank you
everyone for attending.